Perfect. Thank you, Leslie. Oh, I see. I found my button now. Thank you, Leslie.
It's being recorded now.
Perfect. Thanks, Sabine. Great to see you. We're so happy to see everyone here today. Welcome to the August 1st meeting for CMDA. And we give a special welcome to the people from other chapters who are joining us today for this special presentation. My name is Singh Pallet. I'm the president of CMDA. And because we have a great, wonderful agenda today, I'm going to go ahead and hand the mic over to Dr. Leslie Eber, who will introduce our first speaker.
Thank you, Singh. Good afternoon, everybody, and thank you for joining us today. I'd like to introduce Dr. Sunny Linnebur. She's a professor of the Department of Clinical Pharmacy, the University of Colorado Stagg School of Pharmacy and Pharmaceutical Studies. And she graduated with her doctorate of pharmacy degree from the University of Kansas in 1999 with highest distinctions. She then completed her PGY-1 residency at the Veterans Affairs Medical Center in Denver, Colorado, and a PGY-2 primary care residency at the University of Colorado. Since 2001, Dr. Linnebur has provided clinical pharmacy services in geriatrics at the University of Colorado Hospital Seniors Clinic, where she also precepts pharmacy students and residents. Her research and clinical interests are including, and I'm going to ask everybody to Sorry. Can you guys hear me now?
Yep. Yes.
Wonderful. Thank you. So Dr. Linnebur provides clinical pharmacy services in geriatrics at the University of Colorado Hospital Seniors Clinic, where she also precepts pharmacy students and residents. Her research and clinical areas of interest include transitions of care, cardiovascular disease, osteoporosis, vitamin D, dementia, and neurologic disorders. She's an active member of the American Geriatric Society, where she serves on the expert panel for the AGS updated Beers List criteria and is the past president. She's also a member of the American Board of Internal Medicine Geriatrics Medical Board. Dr. Linnebur has been a phenomenal friend to CMDA and the post-acute and long-term care community, and we are thrilled that she is sharing her expertise and her time with us today for this very special presentation. If you have questions during the presentation, please feel free to put them in the chat. And now help me welcome Dr. Sunny Linnebur.
Thank you so much, Leslie. I really appreciate it. And I'm going to go ahead and share my screen. Let me get this going here. Just a second. There we go. All right. Well, thank you so much. I really appreciate the opportunity to be able to speak to you all about the AGS Beers criteria. And as Leslie mentioned, if you do have questions, please feel free to put them in the chat, and then I will answer them at the end of the presentation. I did want to have a slide with expert panel disclosures so that you're aware that none of the authors or panel members of the AGS Beers criteria do have conflicts of interest related to certain drugs that may be reviewed or may be competitors of any of the drugs on the list. And today we're going to talk about some of the changes that have occurred in the 2023 AGS Beers criteria update compared to the 2019 version. And part of that will include a discussion about medications that we should avoid if possible in the elderly, and also how to really utilize the AGS Beers criteria in clinical decision making. I want to first recognize Dr. Mark Beers, for whom this criteria are named after. Dr. Mark Beers was a beloved geriatrician who initiated this project, as some of you are probably well aware, as a medical student doing a geriatrics elective at Harvard. And he completed more training within geriatrics and then moved on to using this criteria and developing it as part of his research projects. So Dr. Mark Beers was very instrumental in this, but when he passed away in 2009, there really wasn't a home for this criteria, and that's when AGS took it over in 2012. You may also be aware that the original Beers list, again with Dr. Mark Beers at the helm, was specifically focused on nursing home patients. And in 1997, CMS started to evaluate this and adopted it in 1999 in nursing home regulation. So it definitely has a long history of use within the long-term care setting. The current versions have been increased in terms of what information is included and have been increased in terms of the focus to include other settings as well. So inpatient drugs that may be used in the outpatient setting, and then also, of course, in the long-term care setting. So the purpose of the AGS Beers criteria when AGS did take it over in 2012 was to really look at drugs that could be potentially appropriate. And this is broken down in the criteria, as you might be aware of, as drugs that are independent of diagnosis. So all older adults over 65 should really try to avoid these medications if possible. Then there's a section on those that are considering diagnosis, so more like a drug or condition interaction, and then drug-drug interactions themselves, and some renal dosage considerations. And this is really designed for the clinical tool, as an educational tool, and as a quality and research tool, but is not designed or intended to be used in a punitive way towards prescribing, or in a way that would eliminate or reduce the availability of medications to patients. For example, the purpose of the AGS Beers criteria is not to encourage implementation of prior authorizations, for example. So the 2023 AGS Beers criteria is really an update of the 2019 criteria, and that 2019 criteria had a date of limit of the articles of 2018. So really all the literature since 2018 was reviewed up until through 2022 for this 2023 update. And similar to previous iterations, new evidence was incorporated, the evidence was graded, an interdisciplinary panel came to consensus, and we incorporated exceptions. These are the panel members. What's awesome about this panel membership is includes interprofessional group, physicians, pharmacists, and nurses. And we actually have 2 panel members, which as a pharmacist, I can geek out over this, but Claudine George and Dr. Claudine George and Dr. Holly Holmes were actually both pharmacists before they became physicians. So we have like 2-for-1s on those 2 panel members. We also have some non-voting panel members, so representative CMS, PQA, and NCQA. We had multiple staff members from AGS who really helped out and provided so much support. And then we also have some other research assistants that were involved in pulling some of the data, for example. So if you're curious about this, we went through a lot of literature. So for this particular search, and we actually went back to 2017 for a portion of the search through May 31st of 2022, it came up with almost 34,000 citations to review. So this is a lot of work for the staff and a lot of work for the panel members. This got boiled down into 1,500 citations of full articles that the panel reviewed, and then 451 studies were used to create the evidence tables. When we looked at the quality of evidence, this is very similar to previous iterations. The evidence is graded by the panel as high quality, moderate quality, and low quality. So that would be based on the type of evidence. Is it randomized controlled trials? Is it meta-analysis? If it's low quality of evidence and it's just observational and there may not be multiple observational studies, then typically that drug is not included on the criteria. We also look at the strength of the recommendation. So if the recommendation is listed as strong, that means that there are harms and adverse events, and the risks clearly outweigh the benefits. If it's rated as weak, there are harms and adverse events, but the risks may not outweigh the benefits of that particular drug. Drugs that are not included on the AGS Beers criteria would be drugs that do have risks, but they're not unique to the elderly. So you may remember a few iterations back, we had drugs that cause constipation. And while those drugs still cause constipation and may be prevalent in older adults, constipation, for example, calcium, could occur in a younger adult as well. So those types of situations are not included in this Beers criteria. Also, it's so important to recognize that the Beers criteria are not appropriate to implement in a hospice setting or for patients nearing the end of life, where these medications may be completely appropriate for those patients. So please know that we would not want the criteria to be applied to those groups. And then we also, for the first time, really considered drugs that had low usage, and we removed those drugs from the criteria. So some key principles when you want to utilize and implement the Beers criteria. One is that they're potentially inappropriate. So that means that there may be situations where these drugs are appropriate. Also, there are caveats that are listed in the guidance. So you may see in the recommendations and rationale that there may be appropriate times where we want to recognize that these drugs should or could be used. And then we also want to make sure that when these medications are evaluated and patients are reviewed for them, that then the providers can start to adjust their approach to those medications. We also want to make sure, again, like I mentioned, that access to the medications on the criteria should not be excessively restricted by prior authorization or health plan coverage policies. With that being said, plans, if there are multiple drugs within one class, may choose coverage for a drug that's not on the criteria and may limit the use of one that is on the criteria if there's a safer alternative. All right, so new to the 2023 update, as I mentioned, we removed some drugs. So you may be looking for these old faithful drugs that you've seen on the list for a really long time, like reserpine. And because of low usage, we finally decided that it was appropriate to just remove that drug. That does not mean that those drugs are appropriate. So we have a list in the full publication that lists the drugs that had low use, less than 4,000 US Medicare beneficiaries during 2020. And what that means is that that drug still is inappropriate for general use, but it was just taken off to reduce the length of the final product. Also, we have an online appendix that compiles all these drugs that were removed with several other appendices, so please feel free to check those out. And we have a section on deprescribing and some resources there as well. So looking at the AGS Beers criteria tables, we have your standard table number 2 with PIMS, potentially inappropriate medications for all older adults. We have table 3, which are the PIMS with drug disease. We have table 4, which is medications to be used with caution. We started that table in 2012. We have table 5, which is an updated, potentially clinically important drug-drug interactions. That table used to have non-antimicrobial interactions. So there are antimicrobial interactions included now. We also have a table with medications that should be avoided or doses adjusted with levels of kidney function that are impaired. We have drugs with strong anticholinergic properties. We have medications removed. We have medications added, and we have medications moved or modified. So those are what I'm going to focus on today. So let's take a look at the first section of drugs that had some changes. So aspirin for primary prevention of cardiovascular disease is now on the full table of drugs that we recommend avoiding in older adults. So previously, aspirin was on the drugs to use with caution list. And this was because there was emerging evidence, but it wasn't quite strong enough for us to be able to have it on the full table. So now aspirin is on there with drugs like antipsychotics and benzodiazepines as a very risky drug. It's really important, though, that when you're evaluating patients and you're educating and discussing this, that it's really important to note this is only for primary prevention of cardiovascular disease. And what does that mean? That means that the patient has not had a diagnosis of cardiovascular disease. They have not had an event. They haven't had a stroke. They haven't had a heart attack. They don't have AAA, for example. So in those kind of patients, you're generally healthy patients. We now have a lot of evidence to indicate that the risk of major bleeding from aspirin is going to outweigh the benefit of the aspirin to prevent that first cardiovascular event. So you may be familiar with the ESPRIT trial. This study has been published since that 2019 update of the AGS-Spears criteria, and there's multiple different reports that have come out from the ESPRIT trial, all showing aspirin to have a risk for bleeding, and the net benefit does not outweigh the net harm. One important thing that we did want to mention here is there's less evidence about stopping aspirin among long-term users, but similar principles apply. So the criteria are that you would not want to initiate aspirin for primary prevention of cardiovascular disease in older adults at all. And you can consider deprescribing in older patients if they are taking it for primary prevention. The quality of evidence you can see on the right-hand side is high, and the strength of the recommendation is strong. Moving on to the next category that we updated, this was really just clarified. Antipsychotics were always on the list. They previously mentioned conventional and atypical antipsychotics, but the rationale was updated to include increased CVA or stroke risk, increased cognitive decline was added, and then increased mortality in dementia is also part of that rationale to avoid antipsychotics. The recommendation is a little bit more complex than what's listed here, but in general, what the recommendation is to avoid these drugs unless there's danger to the self or others and non-pharmacologic therapies have failed. So if you go into the full article, it really goes through more of some approaches to that non-pharmacologic treatment. Benzodiazepines were always on the list. That includes both short and long-acting benzodiazepines. And what was updated here was, again, the rationale. So risk of cognitive effects, negative cognitive effects. You may see impaired cognition in older adults, both with short and long-term treatment. And of course, injury risk was also already on the list. So falls are increased, motor vehicle accidents are increased in patients taking benzodiazepines, but there may be some situations where these drugs are appropriate, for example, in the inpatient setting for ethanol or alcohol withdrawal. Looking at one of the next changes is estrogens with or without progestin. So this is systemic estrogen. And when we look at the data for estrogen, this is sometimes is controversial at the patient level, and it can be difficult. But what we wanted to do was really update and provide clarification, if possible, on the rationale and recommendation based on the evidence. So the evidence shows there's carcinogenic potential breast and endometrium cancer risk, and there's lack of cardioprotective effects and cognitive protection in older women. So the recommendation is for women who start HRT at age 60 or older, the risks are greater than the benefits. And so we wouldn't want to initiate systemic estrogen in those kind of patients. That means oral tablets or transdermal patches, which are also systemic concentrations. And you would want to consider deprescribing among older women who are already using the medication. Evidence, however, is not consistent with local estrogen. So when we think about the risks of estrogen, so the cardiovascular risks, stroke risk, blood clots, dementia, those are with systemic estrogen, not local vaginal estrogen. So the evidence does indicate that vaginal estrogens for the treatment of vaginal dryness and those that have urinary incontinence, that is safe to use. So for women with a history of breast cancer, those women may want to have a more thorough discussion about the risks and the benefits, but in general, the vaginal creams, the tablets are acceptable to use low dose for the management of recurrent UTIs, vaginal symptoms such as dryness and dyspareunia. And the quality of evidence there for the risks of systemic estrogen is high for oral and patches. And then the quality of evidence for the benefit of the vaginal estrogen for dyspareunia, UTIs, that kind of thing is moderate. So that's what that means under the quality of evidence. And then the strength of the recommendation is strong for the systemic estrogens and is weak for the vaginal creams and tablets. So when you think about what evidence is out there, the evidence can vary, and that's why we had to specify in the table which evidence was speaking to what recommendation. Moving on to a really exciting addition to this 2023 criteria is sulfonylureas. So if you've looked at the criteria before, you knew these sulfonylureas have been on the list for a very long time. Chloropropamide was on the list for years. It's been removed because of low use, but we had glyburide on there as a risk. And this time around, there's so much data showing increased cardiovascular events with sulfonylureas compared to other diabetes treatments. So now all sulfonylureas are on the list because of this higher cardiovascular risk issue. There's also data to show all-cause mortality is higher with sulfonylureas than other agents. And of course, we know hypoglycemia can be increased with sulfonylureas. And our older adults are at high risk of all of these side effects already. So it is important to think about how patients with diabetes when they're older should be treated. And now we have so many new options. The one downside is cost. So sulfonylureas are much less expensive than most of the newer agents, which are potentially beneficial for some of those conditions like cardiovascular disease. So if your patient is impacted by cost, then the recommendation in the AJS-Spears criteria is to consider that. And it may mean that a sulfonylurea could be appropriate for your patient. However, if cost is not a concern for the patient, or they have Medicaid and the newer agents are on the formulary, we may want to choose sulfonylureas as a third line option, for example, and avoid it as a first or second line monotherapy or add-on option for diabetes. And what that means is that we may want to choose a GLP-1 agonist, for example, if a patient has cardiovascular disease or is obese, because those agents can reduce cardiovascular risk. Or if they have CKD, we may want to choose an SGLT2 inhibitor for that kind of patient, because that has benefit for CKD, whereas again, sulfonylureas are not going to have that benefit. The quality of evidence is high for hypoglycemia. The quality of evidence is moderate for cardiovascular events, and all-cause mortality increases with sulfonylureas, and then it's low for the outcome of cardiovascular death and ischemic stroke. However, there's still quite a bit of evidence, and that strength of recommendation is strong. Skeletal muscle relaxants have been on the Beers list for a very long time. What has changed in the 2023 criteria is really to spell out the drugs that are used for spasticity. So baclofen and tizanidine are in that same general drug class and covered under skeletal muscle relaxants, but they are used specifically for spasticity. And so this criteria does not apply to those two drugs, although those drugs can also cause substantial adverse effects like sedation. And I will discuss baclofen in a little bit related to renal dosing. So all of the other skeletal muscle relaxants should be avoided in our older patients, and that's related to things like sedation. Some have anticholinergic adverse events. Some, can increase risk of fractures because of falls, and the effectiveness of those agents is not very high. So, for example, cyclobenzaprine would be on that list. The other big area of change for the 2023 criteria, and you may have already heard about this, is with the DOACs and warfarin. So previously on the criteria, on the table of drugs to use with caution, we had rivaroxaban and we had dabigatran. And when we looked at the data that had accumulated, it was very substantial, mostly meta-analyses related to the use of DOACs in patients who were older and in various populations, not just in patients that are from the United States, but in Europe and in Asia. And really the propensity of evidence was very strong, showing an increased risk of major bleeding and GI bleeding with rivaroxaban compared to other agents. And the comparisons were very consistent in that apixaban had a lower risk compared to rivaroxaban, or rivaroxaban had a higher risk of GI bleeding and major bleeding compared to apixaban. So rivaroxaban was changed and moved from the drugs to use with caution to the full table 2 of potentially inappropriate medications. This is a big change, but it is based on a lot of evidence. Now, that being said, there are some certain things that are important to recognize. One, this is for long-term treatment of VTE and AFib. So what that means is it's not the rivaroxaban that's used for VTE prophylaxis in the hospital or in the outpatient setting. It's not the low-dose rivaroxaban that may be used long-term for VTE recurrent treatment. What we're talking about is the treatment of VTE and the treatment of AFib long-term. So the higher doses, like the 20 milligrams once a day and then 15 BID, for example. And that's because apixaban is going to have lower risk of bleeding. Now, we do want to point out that rivaroxaban may be reasonable in certain situations. For example, if the patient cannot remember to take twice-a-day dosing and once-a-day dosing is required, then rivaroxaban may be the best choice for that patient. We did leave dabigatran on the drugs to use with caution because even some of the data indicated that rivaroxaban had a higher risk of bleeding in older patients than dabigatran. So that drug was left on the drugs to use with caution. When we looked at the propensity of evidence, it just had become clear that DOACs in general had lower risk of bleeding than warfarin, and specifically intracranial bleeding is lower with all DOACs, even rivaroxaban, compared to warfarin. So warfarin was added to the Beers list for this 2023 update for table 2. And it's important to note that DOACs are the preferred choice. So this is preferred for both AFib and treatment of VTE. Now, some patients may not be able to afford a DOAC, and so warfarin is appropriate for some patients, for example, those that cannot afford it. Or if the patients have been doing fine on warfarin and their INRs are stable, greater than 70% of the time in the range, they're not having side effects, then it may be reasonable to continue. And there's a really nice summary of all of these changes in the Beers criteria. So like I mentioned, we moved rivaroxaban, we added warfarin, we left dabigatran, but clarified it a little bit. And it's also important to note that all of these drugs have drug-drug interactions. They may have renal dosing. And so there are also recommendations in that renal dosing table. And I'll show you some of those that we modified because the renal dosing is very specific to the indication for the drug. So VTE dosing may be different than AFib renal dosing. And then, as I mentioned, we left dabigatran on the use with caution. So you can see here, warfarin is avoid, rivaroxaban is avoid, dabigatran use with caution. All right, moving on to the next table. These are like the drug and disease contraindications. Delirium was already on the list All of these other drugs were on the list, but we added opioids. And that's because there's emerging evidence of opioids contributing to delirium. So this rationale is much more complete in the actual publication, but these drugs should be avoided in older adults who are high risk of delirium because of the potential inducing or worsening of delirium. And oftentimes this is in the inpatient setting. It may also be in the long-term care setting. And so there's specific language in here related to antipsychotics, corticosteroids, and opioids. And there may be situations where those drugs are necessary or appropriate, but in general, antipsychotics you'd want to avoid in all patients if possible, especially those that have already had delirium. But there may be situations where everything else has been tried, all non-pharmacologic therapies have been exhausted, and the patient is at risk of harming themselves or a risk of harming another person, and that drug may be needed. Corticosteroids, because it can cause delirium, should be used for the shortest period of time and at the lowest doses. And similar opioids should be used only when other therapies have been utilized or exhausted. If the patient requires more severe pain management, and then also for the lowest dose and shortest period of time. So there are some recommendation exceptions there, and that's listed more thoroughly in the full document. Looking at dementia or cognitive impairment, we just really wanted to clarify the antipsychotics. So all of these drugs were on the previous Beers criteria, but antipsychotics were clarified. There is an increased risk of stroke. There's a greater rate of cognitive decline and mortality in people with dementia. And so we really wanted to focus on, like previously it said, avoid for behavioral problems unless documented non-pharm options have failed and the patient's threatening self-harm or harm to others. But what was added, and you can see it in this avoid column here, is if used, periodic deprescribing attempts should be considered to assess ongoing need and or the lowest effective dose. And as you all know, you've been doing this already. So this is really just more supporting what you have been doing in clinical practice in the long-term care setting in terms of trying to reduce that antipsychotic burden. Looking at the table 4, use with caution, this table is really focused on drugs that just don't have quite as much evidence to be on that full table. This is where, for example, we have dabigatran on the list. And because there is a signal of harm or there's a concern, but sometimes the evidence is not quite strong enough. So when we look at dabigatran, we know there's increased risk of GI bleeding compared to warfarin, and this was already in the criteria before, but there are now more evidence showing that is also increased compared to apixaban. So that was added here in the table. We know that dabigatran does have lower dosing that's available that originally wasn't available in the United States. So some patients may be appropriate for dabigatran. It may be on some formularies, but we do want to potentially consider that GI bleeding history at baseline if you're choosing a DOAC, and apixaban would be preferred. Another one that you may see in clinical practice is dextromethorphan quinidine. So this is New Dexta, the brand name, and it's used for pseudobulbar affect. That's what it's FDA approved for. But when it first came out, there was some evidence that suggested that people may see a benefit for dementia-related psychosis. And so not FDA approved for that, was used off-label to the tune of millions of dollars in the United States. But this medication is one that does have a lot of side effects, some of which are more important for older adults. So there's really limited efficacy data in patients with behavioral symptoms with dementia. It may increase the risk of falls, and there are concerns with the drug-drug interaction with quinidine. Quinidine is used for the drug-drug interaction here in this combination to boost the dextromethorphan blood levels to get to a high enough concentration in the brain to treat pseudobulbar affect. And so that drug-drug interaction with quinidine can cause a lot of other drug-drug interactions with older adults. And what we also added here is in use with those with heart failure. This comes from the product labeling where there's a new caution related to the QT prolongation risk with the quinidine component. And because there's a QT prolongation risk, we know that those with heart failure, specifically LV dysfunction, may be at higher risk of QT prolongation. And so that quinidine heart failure is a drug disease interaction, and that this was added because it's included in the product labeling now for the drug. Ticagrelor was added to the use with caution table. Prasugrel was already there, but there's a lot of evidence now, meta-analyses looking at bleeding risk with ticagrelor and prasugrel versus clopidogrel. So as you know, these are all antiplatelet agents. They may be used for secondary prevention of cardiovascular events. They may be used after a procedure. And we do know that prasugrel has higher risk of bleeding in older patients. That's in the product label, but now there's evidence that ticagrelor does as well. So there's an increased risk of major bleeding compared to clopidogrel. This is specific to those 75 and older. And the recommendation is to, if you do use these, use them with caution, especially in those that may be on dual antiplatelet therapies, like with aspirin included. And prasugrel does have a recommendation if patients are less than 60 kilograms that you could consider a 5 milligram dose, but that 5 milligram dose has not been studied in terms of prospective randomized controlled trials for cardiovascular event protection. So that is, you know, part of the recommendation of the product labeling, but in those that are 75 and older, specifically thin patients less than 60 kilograms, that 5 milligram could be considered. SGLT2s were also added to use with caution table. The SGLT2 inhibitors are drugs like empagliflozin, which we would use for diabetes or heart failure. I personally am getting more comfortable with those drugs because I have seen patients that are older tolerate them. So they do have so many good benefits for reducing heart failure exacerbations. They reduce the A1C quite well in our patients that are older, but they do have side effects. And specifically, we have to monitor for urogenital infections, particularly in women in the first month. Also, we think about euglycemic DKA, which is harder to identify. And so we want to use these with caution. We want to monitor patients. I have seen quite a few patients have urogenital infections, fungal and bacterial UTIs, but I personally have not seen the euglycemic DKA in our population at University of Colorado. A few more things that were updated. The opioids, the data were just a little bit stronger now. And so we have a little bit more data on drug-drug interactions with opioids and benzodiazepines, increase in the risk of overdose and adverse events. We see opioids and gabapentin and pregabalin increasing the risk of respiratory depression and death. And really, these were on the criteria before, but they're being re-emphasized with more data related to risks of opioids. Also, anticholinergic drugs, we have a whole table there, table 7, but using multiple anticholinergic drugs increases the risk of side effects. So we want to try to avoid that. You know, we don't want any anticholinergics, let's be honest, but if a patient has to be on one, we definitely want to be careful and not be adding on more. If we look at other drugs like CNS active drugs, there are a ton of these on the list. You'll see anti-epileptics, antidepressants, antipsychotics, benzos, non-benzo, Z drugs, opioids, skeletal muscle relaxants. The combination of any 3 of these or more increases the risk for fracture and falls. So of course we want to avoid that. Kidney function, I mentioned the DOACs are all really specific related to renal dosing. So we took out some of our recommendations because it had been updated in the product labeling of the drugs. And so one of the things that's really important is just to look at the product labeling because those are being updated regularly. For example, rivaroxaban, you want to avoid if creatinine clearance is less than 15 mils per minute. And you may want to reduce the dose, but that's only for AFib, not for VTE treatment. So I just have to look at the product insert myself every single time just to double check that something hasn't changed. We still have no evidence about dabigatran and patients with reduced kidney function. There's no prospective evidence. It's still based on the pharmacokinetic data. One thing that's really important to see here on this drug dosing for renal impairment is baclofen. This was not on the previous list. So as I mentioned, baclofen can be used for spasticity and is not on the criteria to avoid. It's not. So if you're choosing baclofen, the one thing that's important to think about is dosing. In patients with an eGFR less than 60, data indicate that those patients are at higher risk of encephalopathy requiring hospitalization. So if a patient is on baclofen, the data indicate doses less than 20 milligrams a day are going to reduce that risk compared to doses 20 milligram and above. And that's the total daily dose. So for example, like 5 BID would be in that lower dose category, whereas 10 TID would be in that higher dose category. And in patients with eGFR less than 60, if they're in that 20 milligram a day or higher, those are going to be the patients that have that increased risk of encephalopathy. And the reason I mentioned the dose is important because that's based on the data. It's not in the product insert really to recommend a certain dose. So 20 milligrams is that threshold where in patients with reduced kidney function, we really need to be careful looking for CNS toxicity and altered mental status. And then, as you know, NSAIDs have been on the list. NSAIDs are still on the list. NSAIDs should be used very sparingly. So some take-home points here. We don't want, we don't want to let the perfect be the enemy of the good. So as a pharmacist, we get really excited and we're like maybe making 20 recommendations about things that are important. But sometimes we have to look at the top things that are important. And we want to, emphasize this is only part of appropriate prescribing. There are so many other aspects of appropriate prescribing that we have to think about. Some ideas would be to target initiatives of those high prevalence or high severity meds based on your local data, because this definitely fluctuates in different parts of the country. Also, shared decision-making is so important. We want to educate our patients. We want to educate the family if they're available. We may want to educate our nurses. We want to educate our entire medical team. And, shared decision-making is really crucial to be able to weigh those risks and benefits. Also, stopping medication should be done with the same consideration and care as starting them. So that may mean that we have to choose deprescribing of one agent versus deprescribing of 3 agents. And we may need to go slow and taper medications. And we want to point out the AGS-Beers criteria is patient-centered care. So it really is focused on the patient and what the best situation is for your patient. There are some great resources. So there's a pocket card and an app. I'm going to show you what that looks like. We also have the 2015 version, which is a guide of how to use it. We have the Using Wisely, which is a reminder on the proper use. And we do have an alternative medications list, which is coming relatively soon, not in the next couple of months, but maybe in the next year. This is a picture of the app. I do love this new app. It's so much better than the old one. It's $9.99 per year. You can search under AGS-Beers criteria, and it has some really nice features. It's easy to click on the tables. It's easy to sort of see it on your phone, and it does break it down very nicely. We also have the laminated pocket cards that you can order now. So this is the link for the laminated pocket card. You can see here, this is my dog under my desk. I have the AGS pocket card from 2019 that she decided to sleep on it. So I need to order the 2023 update myself, and I share it with my students. So thank you so much. I really appreciate your time coming today for this presentation, and I'm happy to answer any questions.
Thank you so much, Sunny. That was tremendous. What a fantastic presentation. So thank you so much. We do have some questions. I've been writing them down. So the first question is aspirin plus Plavix, because I always mess up how to say it otherwise. That combination, is that too much of a good thing? When would you recommend that? When is that too dangerous for our patients?
That's a great question. So we did consider, we reviewed all of the evidence of aspirin plus clopidogrel and aspirin plus other antiplatelets, looking to see, was there evidence indicating that dual antiplatelet was too risky for our older adults? And there just wasn't enough evidence to support that. and say that, in patients who had a stent placed, for example, we should only use dual and not triple, or we should only use monotherapy instead of dual antiplatelet. So we know there's evidence that dual or triple antiplatelets increase the bleeding risk in our older patients, but there wasn't enough evidence to support adding it to the Beers criteria. So I think it's really important to be in communication with the cardiologist, because usually they're the ones that are prescribing it. But certainly if your patient is, has not had a stent placed or CABG, or hasn't had an intervention that requires dual antiplatelet, and they're using it for just secondary prevention of cardiovascular disease or stroke, then that should be reevaluated to see if monotherapy is appropriate. And then cardiologists cannot really come to consensus either on the duration of dual antiplatelet therapy. So when we think about our older patients, 1 year is really that point where we should continue to reevaluate. And I think it's got to be a shared decision-making situation with the patient, the cardiologist, and the geriatrician or PCP, looking at bleed risk versus their risk of and burden of cardiovascular disease. And sometimes adding a PPI, while I hate adding on medications, the adding on the PPI might be necessary as well to decrease that GI bleed risk.
Thank you so much. That was such a great answer. Thank you. We have another wonderful question from Sabine. Do you find the effectiveness of baclofen or tenazidine for spasticity? Is it truly effective, or is it questionable?
That's a good question. There are multiple studies looking at baclofen. I'm not as familiar with tizanidine data, but baclofen, there are studies looking at spasticity related benefits, and it can be very patient specific. So in our clinic, we do sometimes use baclofen, and it may be more effective in someone, for example, who has neurologic related spasticity that is being treated with multimodalities. So maybe, for example, multiple sclerosis kind of patient. For those that may have just general like back pain, I would say those data are limited. And when we think about baclofen versus other skeletal muscle relaxants, often they are used just for back pain. They may not be used for neurologic, evaluated, like neurology evaluated conditions. So in terms of using it for back pain, we're not supporting that. Hopefully that answered your question.
It did. Thank you. So our last question that we have, and I haven't looked at the chat further. Someone had asked, I'm not sure where this is quite going. What is the recommendation on keeping aspirin with people who have AFib, who have not had a history of stroke or any cardiovascular events? Could you speak to that? It was a question in the chat.
Okay. And I was looking at the chat when you were talking. So let me make sure I understand the question. Was it just keeping aspirin on board in patients who are primary prevention?
Yes, I think that was the basis of the question. That's what I read out of it.
Okay. So the panel decided to add the deprescribing language in there that providers should consider deprescribing aspirin in patients who are primary prevention and over age 60. So that's all of our older adults. And that's based on the Esprit trial, but we don't have very strong evidence yet about the exact risks of cardiovascular events that might occur after deprescribing. So we don't have prospective randomized controlled trials yet of what would happen when you stop the aspirin in patients who are primary prevention. But we do have some evidence on GI bleed risk. So when we think about the patients, again, this should be a patient-specific discussion, but we're actually starting a aspirin deprescribing plan at the university based on some evidence that we have that there are many older adults that are still on aspirin for primary prevention. And we're going to start first with those that are just taking it because they're taking it. And this might not apply in the long-term care setting as much, but if you as a prescriber were not thoughtful about the aspirin and the patient's just doing it, then those patients might be the lower hanging fruit. Or if, of course, if they've already had a GI bleed risk, GI bleed, so they're, you know, way more likely to have another GI bleed because of that first GI bleed, then those would be the low hanging fruit to stop aspirin on. But we support deprescribing, but we don't have enough evidence to say what the risks are if you stop aspirin.
Thank you.
It's a gray zone.
Another question
Oh, go ahead.
is about muscle relaxants for contractures. What are your thoughts on that?
So, Greg, thank you for the question. Can you be more specific in terms of what you mean by the contractures? Are you talking about patients more towards the end of life, or are you?
I like to see people that have had strokes and, you know, over a period of months, they have more and more contractures, they look terrible, and people feel sorry for them, and we put them on usually 2 or 3 muscle relaxants at a time. And just the data that I've read just is that doesn't do anything.
Yeah, I would agree with you. I don't think we have strong data for muscle relaxants in general in that category, but I do think that is an area that providers are using baclofen and may see some benefit in their patients with baclofen. I'm not as familiar with the tizanidine data. I think tizanidine is more of like we don't have as bad of data with it, meaning like it wasn't included in a lot of the adverse outcome studies that included other or muscle relaxants. And so tizanidine is kind of like just there because it wasn't included. But baclofen has more prospective studies. I mean, I think it's worth trying it, but I would, if we use it, it's usually like 5 BID.
Yeah.
At the most.
Thank you. Dr. Christine LaRocca has a question. She wants to know if you could speak about the indications and use of amiodarone in the older population, in our older patients, and your experience with that drug.
That's a good question. Amio, I don't really like amiodarone. Personally, I think it's very difficult for patients to tolerate long-term. Amiodarone is on the criteria because of the risks of pulmonary fibrosis. It causes thyroid toxicity. But in certain patients with AFib, for example, those with heart failure, we can't use dronedarone because of increased mortality risk in patients with heart failure. So dronedarone is on the list for that kind of patient. So, you know, if they have AFib and they have heart failure, amiodarone is still on the list of drugs that is reasonable, you know, for rhythm control. But I would say because of the pulmonary and thyroid toxicities, there's liver toxicities, there's ocular toxicities. I'm not a fan. I really think that it's much better for patients to use rate control, if possible, with a beta blocker or calcium channel blocker, and then, you know, rhythm control is sort of last line. Now, that being said, if our patients are being admitted regularly for their AFib, then usually it's cardiology on the inpatient side at EP that will start these agents. And dofetilide is one that I do see more frequently now. It needs to be renally adjusted and started in the inpatient setting, but we still have patients coming out on amiodarone. And I think the key thing is if they are on amiodarone, we do have to watch for bradycardia. We do have to watch for all of the side effects, the liver, pulmonary, thyroid, and we need to be thinking about stopping it. So like, when can we get the patients back off their amiodarone? Are they stable? Will the drug last for another 100 days? Probably. You know, so we're actively trying to work with cardiology about stopping amiodarone after it's been started and the patients are back into normal sinus rhythm.
Just for a follow-up, Dr. LaRocca says, I have experience seeing patients on amiodarone for rhythm control, and they're still in AFib. So do you have any other insights?
Yeah, I mean, If they're still in AFib, I'm wondering if they're not taking the amiodarone, maybe they're non-adherent when I get it, or it's not effective. Usually, if that's the case and they have permanent AFib, then I would be referring them back to cardiology for an alternate therapy. And we do have other therapies now. It could be even like an implantable device. And so it may be something that, they haven't been back to cardiology and EP and they need to be seen again.
Thank you. Just one other question about amiodarone is, should we switch them to diltiazem and or a beta blocker, and any taper of amiodarone needed?
That's a good question. Usually, if the patient is not on amiodarone, they'll need rate control. And sometimes they're on amiodarone and a rate control agent as well, depending on the patient's heart rate. Usually we use beta blockers for rate control, preferably over calcium channel blockers, just because they may have benefits if they have cardiovascular disease, for example. But diltiazem would be my preferred calcium channel blocker over verapamil, just because it has a little bit less constipation. And then when we think about tapering, we don't taper amiodarone, we just stop it. The half-life is so long that it will stay for a long time after they stop it.
Thank you so much. One last question, and then we are going to turn it back to Dr. Singh Pallet. I see so many people who are on baclofen for years post-stroke spasticity. Do you have any thoughts about that?
Yeah,
is it useful? Is it not?
it can be useful for post-stroke spasticity, but I think that with all drugs that have significant side effects, and especially with kidney function declining over time, potentially, that we should be thinking about the lowest dose possible and, reducing that medication. So if the patient has been on it a long time and they're stable, it may be because the medication's working. But it could also be that over time they overcame that spasticity and don't need the medication. And we don't know unless we alter the drug. So in that case, I would not cold turkey stop anything, but I would reduce the baclofen, maybe cut one dose out. If it's BID, go to once a day, and then kind of see what happens and reevaluate the patient, and then just slowly see if the patient can tolerate without baclofen. I think that's a great idea to rethink it. I don't think it's not a medication that was ever studied long-term like that. And so we have no data long-term. It may be something that could cause side effects over time. And so it's definitely worth reevaluating.
Thank you. Thank you again, Sunny. This was amazing. We are so grateful that you've been here. And I'm going to turn it over to Dr. Singh Pallet. Thank you.
Thank you. Yeah, thanks for your great work with the beers lists. Appreciate you giving us the highlights. We have just 2 minutes left officially in our meeting, but maybe we'll take 5. We have Jenny Albertson here with the Colorado Healthcare Association here to give an update, and also Chad Fear with the Department of Public Health. Thank you, Jenny.
You're welcome. I'm just going to quickly share some slides here, if that's all right. I'll zip through my updates quickly. First off, the Colorado Board of Health did update the mitigation guidance in case we all thought COVID was a thing of the past. Now we have integrated, due to the Board of Health updates in Colorado, into our mitigation guidance, essentially treating COVID very similarly to other disease processes, but including specificity in this separate mitigation guidance for outbreaks and so forth. And that is for both nursing homes and assisted livings. It's different for each. So there are 2 separate documents, and they're linked here for you, Singh, when I send them to you. Highlights for those, the main things that have been changed. They did remove the requirement for EM resource reporting. That mandate, their authority for that has expired. Also, they provided new links to the updated respiratory protection program, which has been completely modified to gel with the OSHA requirements. And I think we've all been privy to that implementation being a big push with the department. And then the vaccination and treatment section has been aligned with the Chapter 2 requirements as well. So all of this is essentially just codified and unified. They also added recently an infection risk assessment tool, which is very much akin to an emergency preparedness style assessment, where you look at the potential for, say, for example, hand washing to be inadequate. And based on the potential for that, you build your infection interventions upon that risk level. So they will start surveying to this particular tool or something that mimics the elements of it by January 1st. It has been part of the requirements in F880 on the federal side. Now it is also part of the Chapter 2 requirements. And assisted livings also are required to complete something of this variety. The fact that they've created a template for us is a good clue as to the elements they want to see, but it is not particularly mandated that we utilize that tool. Just a quick update on sales and closures. There is another closure occurring in Colorado Springs, and that's Namaste. They do have a dementia care unit, and they are sending a lot of their folks to Falcon Heights, who has just opened a dementia care unit. So there is a place for folks. We still do not have news on replacing the VA contract for long-term care in Colorado Springs. The irony of this is incredible to me. It's a veteran-centric community, and we have no VA licensed contracted skilled nursing long-term care available that is in Colorado Springs. Also, Genesis is selling all of their properties in Colorado to PACS, who also just recently acquired some properties of Vivage, and they will be changing all of those names, but that is the current list of names held by Genesis. So that is happening with with a lot of rapidity at this point. This has been in the works for a couple of months. This is an interesting slide for you to reflect on when you have a few more minutes. Overall, the direct care workforce survey that they did from the Direct Care Workforce Collaborative through HCPF and the ARPA funding had some really positive things to say about how people feel about being direct caregivers. This is all the way from home care to those that work in skilled nursing. Satisfaction with the job itself is at 92.4%. People love to do the work. And also the wages and salaries has largely been rectified after and through COVID to the point of a 71.6% satisfaction with wages and salaries. Benefits is still half and half. And we still have a contingent of folks that would not recommend this type of work for others. But generally speaking, this shows an improvement. So I wanted to note that for you all in case you hadn't seen those stats yet. And then this is just a quick summary of our legislative session outlook for the next year. Our session is only 120 days in Colorado. It starts in January, so we're prepping at this point, but I like to give you a picture of what nationally is on the docket. The staffing mandate is still in the works. We're expecting that to come out soon with a glide path of implementation of 3 to 5 years. We're really hoping that they will increase immigration policy for visas for nurses, particularly. Fingers crossed that we can push that in conjunction with a lot of other healthcare association push. And then the CMS mandate for a 2-year prohibition on nurse aid training in facilities that have a fine over $10,500. We're looking for that to be taken out of the Social Security Act, meaning it will take an act of Congress. So we're hoping that ACA will be able to push that further. We've been halfway through that process multiple times. And then locally, state-wise, we really don't have a whole lot on our docket. Most of our positioning will be reactionary this year because our Medicaid funding is looking pretty good for the next couple of years. And then these are our upcoming opportunities. And that's it. I'll send these to you. Thank you.
Yes, so we appreciate it. It looks like we even have interest from Washington State. And so if you don't mind, we'll do a regional distribution of this update.
Sure, absolutely.
Thank you so much, Jenny. I might have some questions for you about some of those things offline. Chad, are you still on?
I am.
Chad. Thank you.
Hello.
Chad Pierce
Right.
here, CDPHE.
So I have a few things, give you some non-duplicative information, just kind of some rubber hit the road, meets the road kind of stuff. We did an abuse prevention conference, rather a collaboration. I like collaboration better. We did that in June, and we're going to continue with this conversation in August 8th in Pueblo, and continuing to have those conversations about identifying, what is abuse, and really having conversations about that preventative, the proactive kinds of things that can be put into place to prevent particularly resident to resident types of abuse from occurring. Did want to let y'all know that recent immediate jeopardy situations have included K918 emergency generator that was in disrepair, neglect related to lack of supervision, an immediate jeopardy situation related to elopement from a facility, and quality of care related to failure to respond to acute changes in condition. Did want to, we talk about this from time to time when we do get together and meet, that just remind everybody that there continues to be a growing emphasis being placed on the emergency preparedness program, which we really believe will likely become a quality review by surveyors, in addition to being a documentation / policy review. There's a growing emphasis, continued growing emphasis being placed on the QAPI quality assurance process, and a continued growing emphasis is being placed on staffing and how this affects care. I did receive a question, and Dr. Dom, I figured I would go ahead and answer it here. I owed you an answer. And this is about side effect monitoring for opiates, and whether that is now a CMS Appendix PP requirement. So there is new language in the state operations manual that was revised in October of 23 that does address opiate side effect monitoring. And so a facility would be expected to monitor for typical side effects, such as all of those typical ones. I'm getting ahead of myself here. Increased sensitivity to pain, constipation, nausea, vomiting, dry mouth, sleepiness, all of those kind of things that you might see. And I know that one of the points of the question was there are so many things, and the common side effects for opiate use can be so vague. So we would expect that some of the more common kinds of side effects are being looked for. We would also look to see that that maybe that there's a list that is specified and individualized, perhaps based upon the resident's history or experience. We would want to see that there's consideration whether new side effects are associated with a specific medication, the opiate, or other medications, and consider whether the medication use has affected other areas of concern, increase in falls, delirium, those kinds of things. And then we would want the facility to engage in a process of monitoring, reevaluation, and care plan revision, and expect to see communication with the physician, and that there was some form of risk benefit statement or consideration of the risk and benefits of the continued use of the medication. I did want to note just the last thing for us here in Colorado, the pre-admission screening process. So the PASSAR process in Colorado no longer uses the Beers list, but they've transitioned to what they believe is a more person-centered process. So in addition to diagnoses and prescribed medication, they do more of an entire systems review. Now, what I can say for survey is that the reference to the Beers list is included in the state operations manual. And so when surveyors are out in the facility, we are definitely referring to the Beers list in terms of looking at the broad range of adverse consequences, medication interactions, and those kind of things, and ensuring that medications are not at excessive dose for excessive duration or without adequate monitoring. So pass our process. It's not necessarily required. For the survey process, we do look to see, we reference the Beers list in terms of our assessment of compliance with the use of these type of medications. And with that, that's all I have for you.
Thank you, Chad. That's a great clarification. Thanks for tying it all together for us too. If anyone has any further questions or comments, we're happy to take them. It looks like in the chat box, there is a thank you, Tim, for California Dementia Partnerships sponsoring a webinar on improving resident-to-resident relations. Great, thank you. Okay, especially for the resident aggression. Yeah, we appreciate all of your updates, and thank you all for joining us for today's presentation, and we are very grateful for all of our speakers. Our September meeting is actually not going to be held on the usual first Tuesday of the month because it falls right by Labor Day. So we will see you all the following month in October. Thank you. Bye-bye.